Hello, everyone. My name is Giovanni Nogales, and I'm a paralegal here at Liles Parker. Welcome to today's webinar hosted by the Texas Association for Home Care and Hospice. Today's webinar is entitled Risks Facing Your Home Health or Hospice Agencies if you hire someone on the OIG Exclusion List or the CMS Preclusion List. This is just a quick reminder. If you have any questions throughout the presentation, please feel free to type them in the chat box, and we will address as many as possible at the end of the presentation. So without further ado, I present your speakers, Robert Liles and Paul Weidenfeld.
Thank you very much, Gio. This is Robert Liles, and I'm the managing partner here at Liles Parker. Most of you know a little bit about my background. I'm a recovering hospital administrator, worked in hospitals for many years, and then I went to law school and served as an assistant U.S. attorney in the Southern District of Texas. And I was detailed to Washington as the nation's first healthcare fraud coordinator for all the U.S. attorney's offices in the country. And I'm here today with my good friend, Paul Weidenfeld. And Paul and I, gosh, Paul, it's embarrassing how long we've known each other. We've known each other since we both started at DOJ many years ago.
I've known you since you've been recovering for the entire time I've known you.
That's exactly right.
In the 90s, that's right.
And Paul was in AUSA in New Orleans. And he has an incredible background. He's done everything from admiralty work to argued in front of the U.S. Supreme Court. The reason why I wanted Paul here today for this particular presentation, other than the fact that he's really very knowledgeable about just about everything when it comes to healthcare fraud, but he is, in my opinion, the most knowledgeable person in the country when it comes to Medicare exclusions. And that's what we're talking about today is Medicare exclusions, isn't it, Paul?
It is. It is a topic that I would say I'm well versed in. I don't know about knowing more than anybody, but I know enough, I think, to maybe help.
I've read your articles that have been in journals, and I've seen you talk about these issues, and I know that you're one of the principals at exclusionscreening.com. So it's great to have you here, Paul, as kind of a subject matter expert on these points. So, Paul,
it's always fun, and thank you, Robert, for having me. It's always fun to do webinars with you.
Thank you, Paul. So, Paul, what is an exclusion? Just in 2 seconds or 30 seconds, what is an exclusion?
25 words or less.
Yes.
If I can do anything in 25 words or less, I'm not sure. But it's basically an administrative action that's taken by the Office of Inspector General. And so it's a different process, administrative process versus in courts and so forth. It's an administrative process. It's a final action that essentially bars participation in all federal health care benefit programs.
Not just Medicare and Medicaid.
No, and Medicaid, for these, although Medicaid is administered by the state, it is still, for the purposes of exclusion, a federal health care benefit program because it's funded state and federally. So it's not just, it's Medicare, Medicaid, CHIPS, TRICARE, VA, FEHBP, federal
retirement.
Railroad retirement, and I think that's probably most of them.
That's all the big ones that we are aware of.
That's right.
Okay, next slide. All right, so just in terms of the history here, looking at exclusions, one thing that kind of always jumps out at me, Paul, is when I talk to people, when we go to conferences, when I'm invited to conferences, when we're talking about various healthcare fraud issues, exclusions come up. And about half the time, folks just look at me like, what are you talking about? This is probably the least known risk area from a regulatory compliance standpoint out there, isn't it?
It really is. And it's surprising on the one hand, but on the other hand, if you look at it, going back 1977, so that's what, 50 years?
Yeah, almost, just about, yeah.
So since in that time, almost 50 years ago, the idea of an exclusion is to bar the participation of a bad actor.
And why would they do that?
Well, how you do anything is how you do everything. At least that's what a lot of psychologists will say. And it is true in many ways. So once someone is a proven bad actor, and we're going to talk about why they're, once they have someone that doesn't belong in the program, they want to keep them out of the program. And when they say keep them out, keep them from participating, from posing risks to patients and posing risks to the federal government, to the funding. And so it's the idea of excluding, keeping certain people out of the program and away from harming the government and from people. And it's a pretty simple idea. Now, they've been working on it since 1977. And so the first ones were pretty mild, and it just included physicians and very specifically. And then they had some civil money penalties in 1981. And you can follow this track going along. And in HIPAA, they had a lot of money for it. The Affordable Care Act sort of outlined the idea of how state exclusions can be used to be expanded to other states and even the federal government. So they've been working on this.
And let's talk about that for just 1 second.
Okay.
You have federal exclusions, OIG, but then you have a separate authority by the states themselves.
Absolutely.
So each of the 50 states, I think that right now all 50 states do take Medicaid.
I believe.
At one point it was only 49. There was one state that didn't get the funding for whatever reason. But all states that take Medicaid also have the authority. They've set up, MAFUCUs.
They are required, every state is required to have a Medicaid fraud control unit, which is called the MAFUCU.
Okay.
And they all have authority to exclude people from their Medicaid programs, which may or may not be the same thing as a federal exclusion by the Office of Inspector General. But they can keep people from their own programs as well.
Now, I may be jumping ahead.
Okay.
They're supposed to report those exclusions for inclusion on the federal registry, aren't they?
So that anytime they impose, so a state may impose an exclusion for any number of reasons. But if they exclude somebody for cause, basically for something related to fraud, program integrity, patient abuse, if they exclude somebody for that reason, or licensing, which would be one of those reasons, they are required, they may still not fulfill the requirement, but they're required to report those to the federal government.
That was my point.
To the Office of Inspector General.
Which is, they're supposed to, but they don't.
But they may not. Or they may take their time on doing it. Or they may, whatever. And
it's an imperfect system.
It is. And they're not only supposed to do it there, but they're also supposed to make it available to their sister states. Because the sister states, if that person is also a Medicaid provider in their state, they're supposed to evaluate whether the exclusion in state A also qualifies as an exclusion in their state. And then they're supposed to proceed there. Some states are pretty aggressive about that.
Next slide. All right, so let's kind of step back again, and let's focus just on the federal exclusions.
All right.
The ones that are enacted by the Office of Inspector General. Now, it's my understanding that exclusions essentially come in two flavors: mandatory and permissive.
Correct.
What is a mandatory exclusion?
Well, it's an exclusion that the Office of Inspector General is supposed to impose for one of four reasons. It's pretty simple, okay? If, in fact, you have been convicted in any connection with the delivery of service to a federal or state healthcare benefit program, and that's any kind of conviction, misdemeanor, felony, whatever, any kind of conviction for something related to Medicare, Medicaid, and so forth, that's the basis for a mandatory exclusion. That's A1. A2 is a conviction under federal law for abuse and neglect, okay, of a patient, and that's fairly substantial. The third reason is a felony conviction to a healthcare program that's not a healthcare benefit, that's not a federal program. In other words, if you are convicted for defrauding a private
Blue Cross Blue Shield.
Exactly.
Okay.
That's fairly rare because generally, if you've been convicted for that, you've also been convicted for Medicare, Medicaid.
Very few bad guys out there only do private.
That's exactly right. And then the fourth one is certain drug offenses, mainly distribution, high-level drugs. If you are convicted of one of those, then that would be the basis of the mandatory exclusion as well.
Now, you've used the word conviction here in all four.
Right.
You and I had a very interesting discussion yesterday about what the term conviction means, didn't we?
Well, yes, we do. And it's interesting very much because you can see the A2 through 4, those are felony convictions. Okay? And so that's pretty easy. But A1, which is the largest segment of a mandatory exclusion, it's just defined as a conviction, not a felony, any kind of conviction.
It could be misdemeanor.
Well, not only that, actually, the regulations provide that a conviction is any type of final finding, and it includes, for instance,
deferred adjudication,
a deferred adjudication, anything that's deferred. It can be a no-low plea.
Mm-hmm.
It can be, a expungible offense. All of those are considered convictions if, in fact, at some point there's an admission of guilt, and then they pull. You can't, like, a lot of times what they'll do is they'll withhold the sentencing, or they'll allow you to withdraw the conviction later on.
But it was still, at some point, it was entered.
And that's
the key, isn't it?
That is
because I recently had a case, or I've got a case now, where what was negotiated on behalf of our client was a non-prosecution agreement, where there is not a filing of a conviction.
It's very interesting. Like in Louisiana, when I was prosecuting there, and when I was a defense lawyer there too, in state law, they had a 983 and 894. So, like, they seemed really similar. But one allowed a defendant not to make a plea, but they would withhold it, and then if they put him on probation, and then they would let it go. So he never ever entered anything. But the 8.
So that's kind of like a non-prosecution.
And that was okay.
That's okay.
But
that would not trigger this.
No, but 894 was an expungable offense, and so you would plead, and then they can expunge. That
still triggers it.
That's a conviction.
Very interesting.
It was
very interesting. Okay, next slide. All right, so these, my goodness gracious, these are all the permissive exclusions. Now, understand, when it comes to mandatory exclusions, OIG doesn't have a choice. If they learn about it, and they're going to find out about it on the federal side almost always, on the state side, sometimes it takes a while before they hear about something, but they will still implement that exclusion.
And it's interesting the way you said it. They are mandated to do it, but they may not hear about it, particularly, say, crimes related to patient abuse and neglect. They don't always get those.
It's weird, because a lot of times they're prosecuted by the state.
That's right.
And the state's not good about reporting things.
Right. Exactly. So so they are supposed to, and if they get it, they will in fact prosecute.
Right. Even if it's 2 years late, they'll still do something.
The permissives, it suggests much more so that it is optional.
Yeah.
And I'm not, and
but
so,
that's really misleading, though, isn't it, Paul?
Well,
from a practical standpoint.
From a practical standpoint, it's very interesting. They don't really do it on the basis, well, do we want to or not? It's generally based on whether they can win or not. And this goes to the idea of what is a conviction, and by the way, and so here we go, we're going to dig a little deep, go underneath into the weeds a teeny bit. If there's a conviction and it's used as the basis for an exclusion, you cannot question that conviction in your exclusion process.
And that's what they meant earlier when they said that it is a final administrative action.
Exactly.
You cannot attack the underlying conviction or the underlying administrative ruling.
Exactly. So once the conviction is there, that's done. All you can appeal from there is your sentence, the length of an extension. And by the way, a mandatory exclusion is for at least 5 years. Permissives are generally at least 3 years. Now,
what's the longest you've ever seen for a mandatory?
Oh man, I don't
know.
Just about. They don't.
I've seen some 50s.
Oh yeah, I've seen where they will do it to a point where it will extend the individual's lifespan.
Yeah, where they just do not want them ever involved in the program again. And a lot of times, I've seen a couple of cases fairly recently up in the Northeast, where as part of the plea agreement,
yes,
the provider agreed to never apply for Medicare again.
It is not uncommon.
And to be always excluded.
It is not uncommon in criminal cases for them to add on an agreement as part of the plea agreement that they will never apply, or that will be agree to an exclusion for a certain number of years. That's not uncommon.
But some of these things for permissive are really kind of benign and kind of bother me. One of them, for instance, is, and you and I have seen cases where guys were excluded because they didn't pay back a federal loan.
Okay, so the permissive exclusions are very interesting because they have spent a lot of time and legislative effort to keep enlarging this list. and most recent ones, or they've increased it to whether people have, whether an excluded, an owner was previously excluded, and they fail to identify them in the application process. But as a practical matter, the exclusions that they proceed to the permission ones are before the license revocation or disciplinary matter, because just like with a conviction, they cannot question the underlying matter, the underlying basis for that. So that's automatic. And what you just said, the failure to pay loans, those are final actions. Those are adjudications. They've been found that they haven't paid and they've defaulted, they're in arrears or what have you. They can't question those either.
Right.
And those are the, over 80, almost 90% of all permissive exclusions are based on the licensure.
Yeah, and most of those are what? Nurses.
They are. They are nurses. They are CNAs. They are, they are people who have, who are touching the patients essentially.
And that is so important for the folks on this call, because who do our home health and hospice friends employ a lot of?
The nurses.
And so you gotta be careful, guys. You gotta be careful.
So if you think about what they're concerned about patients. They are exclusions are really protecting patients and the fisc and the dollars.
That's the purpose of it. It's not just a check the box. Screening for this. People like to think of it as, oh, it's something else I got to do. No, that's the wrong way to approach this, because it really is important to your patients and their safety.
So and the reason they have these exclusions, they're looking for bad actors. They're looking for people who who have risk. And who are the kinds of people that they would be most concerned about? Well, they are concerned about the people that touch patients and that go to houses, which is home health, right? And they're concerned about the money, and then you can't watch what someone in a home actually does.
And that applies to hospice as well.
Exactly. And so home health and hospice really have targets on their back
when it comes to this issue, especially
particularly with this exclusion issue, as well as with others.
Okay. Now we're going to talk later on in this webinar. We're going to be talking about what you can do to reduce your level of risk and meet your obligations. Okay, but we'll save off on that. The next slide. Oh, all right. So let's just say that you hire somebody, and this happens all the time, where they bring in a nurse, and in fact, we've seen cases recently where they used a staffing agency. And the staffing agency, they're supposed to be screening, but they weren't. So they bring in a nurse from the staffing agency, and it turns out that nurse was excluded. Who is responsible possibly for the CMPs there?
Well, I would say that certainly if you have used that person who was excluded, you're going to be
home health and hospice.
You're the hospice, yes, the home health or hospice. You're going to be on the hook because you're the one that brought that individual into somebody's home or into somebody's hospital room or into
build the program for their services.
That's right.
Which is the key, really.
That's exactly right. So we're going to talk in a minute.
And I just want to remind everybody that just because you're excluded does not mean that you're not licensed or that you're not qualified. There are lots of cases we've seen where the doctors kept their license, but they were still excluded because they were convicted of a felony.
Absolutely. I mean, the licensure board, first of all, the exclusions on a mandatory are very long, at least 5 years, and sometimes longer, and even on the permissive, just the licensing. But they will often get your license back, but well before you can resolve your exclusion. I think we talked about later.
So it's not enough that you verified their license, okay? That's not enough.
That's really critical, Robert. You're absolutely right. You can't just go to the NPDB and say, oh wait, they've got their license back, or you can't go to the licensing board and say, is he now a doctor? Are they now a nurse? That doesn't mean that they're off the exclusion list.
Okay. All right. So you can be subject to significant civil monetary penalties.
So the slide before is the penalties.
Yep.
Let's go back one slide. There it is. So in other words, what they're doing is and they'll say, what's the rule that says I have to screen so many often? Well, there is no rule that says you have to screen this often, at least not for Medicare. There is for most Medicaid.
Okay, let's talk. Let's just turn the lights on there completely.
Okay.
Is there a law that says a federal law that says I must screen my providers.
No,
There is no federal law.
that says that.
But really, it's really
So go back
the
around.
carrot and the stick, isn't it?
Well,
Because if you don't screen and you bring someone on who is excluded,
right. So and we're going to talk about the full impact of
there's really no excuse. There's no way out of it.
you are going to be responsible. There are civil money penalties if you employ an excluded partner, if you hire a vendor who is excluded, or if you submit a claim for a service that an excluded person provided, either directly or indirectly. In other words, let's say you are excluded, Robert. Now that would never happen. I don't know. But let's say if you were excluded and you were to provide a widget that I could use in my practice, okay? And I now take that widget and I bill.
So I sell my widget to you.
You sell to me, and I use that widget to provide a service and bill for that. I can't do that because you can't participate in the program directly or indirectly.
That's right.
If I submit a claim, if I hire somebody, and or I do have a vendor, they can impose these civil money penalties, and they are insanely large. Not to mention the fact that it's an overpayment. Not to mention the fact that there's also it's an overpayment and
other potential damages. Next slide. They've got potential assessments as well.
They do, and these assessments are always weird things. They're like supposed to pay.
I don't really see those really being assessed very often. I mean, no, most of the time, if they're going to hit you, they're going to hit you with CMP.
Right. It's supposed to be for you the costs of the investigation and the costs of the prosecution.
Gotcha.
You know, if you're getting into the assessments, you're either really in trouble or they're trying.
They hate you.
Yeah, they're like, you're a nail and they're the hammer.
That's right.
Bam.
Yeah. So it's there, but they rarely exercise that authority. Next slide. All right. So, we've talked about exclusions. We've talked about there's different types of exclusions. My goodness, this is a pretty comprehensive list of all the different places that you really are supposed to be checking, isn't it?
Well, yes. I mean, so the OIG, the Office of the Inspector General, posts its list every month, and it amends its list every month, and it pulls people off.
And that's the 800-pound gorilla. That's the primary one that people worry about.
And there are about 75,000, 80,000 people on that list.
And there's people always going on and people always coming off.
Right. More go on than go off typically.
Yep.
But that's the way that is. There are also every state, if you had said, well, not all states have sanction lists. I think 44 do.
The others, some of them say,
well,
we send everything to OIG so we don't have to maintain our own list.
And when they first started doing laws, they were permitted, as a matter of law, to rely on the OIG's list. And that would mean that they would send all their state stuff there. Honestly,
it doesn't happen.
It doesn't work
That's
out.
The problem.
But they're allowed to do that, and I think 6 or 5 states now do. The others all have their own list. The problem with those lists is that they are often posted in different places. They're not posted routinely. Between the 9th and the 12th of the month, the OIG is going to update its list, okay? Between the 1st and the 31st of any given month, at any time, a state may or may not update.
And the problem with the states is they change the location on their website if they're going to have it on, all the time. Sometimes it's on a PDF. Sometimes it's an Excel spreadsheet. Sometimes it's just who knows what.
Word.
That's crazy stuff.
Yeah.
So it's really hard for providers to really go in and try to do their own screening.
And we're going to talk about that, I think, in a bit, about how we screen and
stuff.
Now,
on this list, what I mentioned here in this presentation covers the preclusion list. What is a preclusion list? And, do any of the folks on this call have access to it?
No, they don't.
Which is kind of unfair.
Which is kind of, well, yes. It's as in Part C and Part D, as everybody probably on this call knows, the CMS has backed away from credentialing folk, and so the different providers, the different payers, they credential, and this is CMS's idea of letting those payers know about people that they think are bad actors and that they don't think should be providing services to Part C and D. That's the idea. it's like, it's not, it's supposed to be additive to the OIGs, their list of excluded individuals and entities, the LEIE. I think it's kind of more closer to like what if CMS would revoke somebody or has revoked somebody,
yeah,
and they're not on the list. And
we'll talk about that in just a
yeah,
few minutes.
that's
It's not
fine.
really clear.
All right.
Okay, next slide. Well, let me back up for 1 second. Go back real quick. There's also the, go back one slide, Gio. There's also the GSA SAM.
Okay.
Just very quickly, that is the list of companies that have been debarred from doing business with the government. Not necessarily healthcare. It could be defense contracting company.
So it's very interesting that so sometime in the recent past, every agency, every federal agency had its own debarment list. That is,
right.
People that they would not do business with. It didn't mean they committed fraud. It didn't mean, but they put them on their debarment list. Then they had the idea of, all right, it was called the EPLS. People may remember that. They put them all together into the General Services Administration, statistically, whatever, the GSA SAM, okay? That's the combination of all those lists. Now, there are about 150,000 people on that list. However, everybody, people and companies,
yes,
everybody from the OIG's list, the LEIE, is on that list also.
Okay.
And sometimes twice because OPM puts them on that list. And it also, a large part of it are people from Treasury, from the OFAC, from the folks that the terrorist watch list.
And that's interesting that you bring up the OFAC, because more and more we're seeing providers being asked, have you checked, two things we're asking them, have you checked the OFAC, which is interesting to me. I actually wrote an article one time on this, because it was surprising how many DME companies over the years have in fact been added to the OFAC because they were doing business with Iran or they were doing something improper, So anyway, and then the other one is the death registry. Have you checked the Social Security death registry?
Right.
My point is, every one of your contracts, okay, with private payers and with the Advantage plans or the Medicaid managed care plans, check them out, guys. They may have a little tweak to what they expect you to do.
Very important that you mention that, because contractually, you may be required to screen with OFAC. I have seen that. Now, personally, I have compared OFAC with the people on the GSA, and it's pretty much one and the same.
Interesting.
Most of them. So I don't know why they do that. But
I don't think about the OFAC, but they definitely have more interesting stories behind them.
They do. And the GSA people, the ones that the death registry that you mentioned, the idea there is that they're concerned mostly about beneficiaries using somebody else's Medicaid or Medicare number, but they're also worried about providers using somebody else's number and posing, kind of stealing their, and
about every 3 years, OIG comes out with a new report talking about how they're still billing for dead people, and Medicare is still paying them. What in the world is going on? And, that happens, just very quickly, happens two ways. Number one, your biller screws up. They bill for service on the date that they process the claim, not the day that the claim was rendered. That's one way it does. And then I've also seen cases where a provider trying to help an elderly person, it would only, the plan would only cover so many injections per month, but this patient needed them every week. So what they did was they charged 2 of them for this month, and then they waited and do it the other 2 the next month. The problem is the provider didn't know that the poor patient died. Now that's a double problem, because not only did he, affirmatively set out to defraud the system in terms of falsification of dates, but he did it knowingly. So
I will say, Robert, that in my experience, and I have, I was a public defender, I was a federal prosecutor, and all kinds of things in the middle. And in my experience, it's pretty rare for someone. It does happen that someone uses grandma's Medicaid number.
Yes.
It does happen. But honestly,
I think Social Security fraud is more prevalent than
probably
Medicare
so.
fraud.
Yes,
Numbers, yeah.
that may well be so.
Yeah.
But there's an awful lot, when they're requiring the death master file and all these things, there's an awful lot of energy going into attacking a fraud that may cost a tiny fraction
It's so small.
of the,
Yeah.
I mean, really. I mean,
But it's
anyway.
but that's OIG hates it. Next slide.
Yeah.
Okay, so we talked about how an exclusion is a final administrative action.
Right.
Okay, it's based on the, you can't attack the underlying case and the rest of it. Now, you had mentioned a couple of times how if someone is excluded, they cannot bill for services directly or indirectly. Okay, and the other thing to point out is it's not just employees, guys. It's contractors, vendors, and agents. Okay, so essentially, your point, Paul, is Medicare doesn't want anybody who is, as you say, a bad actor, and we kind of stole that phrase because that's a phrase that comes up on the preclusion side, but they don't want bad actors getting near or providing services indirectly or directly to Medicare beneficiaries.
It actually, bad actors is a phrase that they use going back into the 70s, right?
Oh, wow.
Yeah, they
Okay, well, then preclusion then stole it from then.
That's exactly right.
Okay.
But, the idea is that once they've been determined, okay, that you're a bad actor, a lot of times there's a backstory, and there really is. They're not so bad, right? But you don't get to look to that backstory.
That's the problem.
You just don't. It's like, it's final. And it's like an arrest, you can question whether, yes, you don't get to question. So what happens? An excluded party, it's, as you would say, the atomic bomb, Robert. You cannot do anything if you are excluded, and you can't bill for anything. For instance, it's actually a crime for someone to try and participate in the program. You can't become a biller. A doctor, there was a case in Louisiana where the doctor was excluded. He tried to become a biller. He was prosecuted for that. They said, no, you're not allowed to do that.
Louisiana is very unique. There it actually is a criminal offense.
You know what, Robert?
To be billing for services if you're excluded.
I've looked at a few other states. It's not just Louisiana. It is actually.
I just like to think of it as Louisiana only.
Well, I have some fondness for Louisiana. But anyway, having been there for many years. But
this is an interesting example up there that you and I have talked about. The highlighted in red down towards the bottom. That was a doctor who still had his license, was seeing Medicare patients. Now, he couldn't bill Medicare for seeing those patients, but he was seeing them. Who knows how he was getting paid? That is not addressed in the case. But what he did, though, is once he saw them, which was perfectly legal, he wrote them a prescription, which is also perfectly legal.
Yes.
But then those Medicare patients took that prescription to a pharmacy, and the pharmacy filled it and billed it to Medicare.
And the pharmacy's on the hook.
The pharmacy's on the hook and had to pay lots and lots of money. That's a perfect example of indirect.
And that is really applicable in home health and hospice, where you are acting on a service based upon a prescription, the order by somebody.
So important. All these referrals that you guys are getting, okay, you better be checking not just your employees, but also all your referring docs.
Absolutely, because when they make referrals, they are allowed to make. They may be licensed. They may be the best doc in the state, and they can be licensed.
And the prescription is good, but it's not good for purposes of being billed to Medicare.
Exactly. And
they could go to private, some kind of private person that's going to do home health private, if there was such a thing.
If there was, and the problem is, of course, since the feds won't pay, right? The state Medicaid programs, they won't pay.
Right.
And the privates have basically glommed onto that and said, well, if nobody else is paying, why should we pay?
Well, and the reason they say it is, that's stupid for us to put our patients at risk if the feds won't do it and the state won't do it.
And it makes complete sense. If we start with the premise that the person who is excluded is a bad actor and poses a risk as a matter of law, well, then it makes sense that you don't want to do any service based upon his order or action.
So it's a real problem, guys, because you can take that prescription, that order from that doc, and it's a perfectly valid order. But if you're basing then Medicare or Medicaid services off of that order, and you're later audited, you got a problem. And see, what happens is the government's not stupid. You know, at some point they figure out what's going on. They
Not always anymore.
Not always. But eventually they almost always find this out.
Yes, they do.
And then they go back and they see, okay, well, we can do a sort in our system here to see who were the referring docs that were excluded.
And one other thing that's really worth mentioning is that when you're in a business like home health and hospice, you have a heart, right? And I mean, it just, you don't do this unless you care.
No, you're looking for a reason not to be able to. I mean, or you know, you want to admit them.
And people people may come to you and say, look, they may tell you that they had some trouble in the past, but you know from whatever, the people that know them from church, wherever, that they're really a good person now, that was a mistake. But the problem is, if they've been excluded, right, you can't find a way around that. Mm-hmm. It's almost impossible.
That's right.
And so you just, you can't put yourself at risk even though you might want to.
This slide, I think we've already covered most of these issues. Just go to the next slide. Okay, so what is the best practice?
All right, so so the way they get around the fact that they don't have a rule that says you have to screen every month, and they have posted guidance. They said in 2013, the OIG posted guidance, and it was shortly after that guidance that exclusion screening was begun. They posted guidance that said that if you don't screen upon employment, upon hire, and every 30 days thereafter, you are going to be subject to all of these civil money penalties. Every claim you bill is going to be an overpayment, and who knows? And there have been cases that actually turned into False Claims Act cases. So the only way you avoid that risk is by screening every month.
And you don't really avoid all the risk, because even if you catch it, okay, you're still responsible for paying back the overpayment.
So let's say you caught, and if you screen upon hire and they're not on, if you screen upon hire, you should catch it then, and certainly you screen it every month. So you're not going to have a penalty, and your risk is going to be pretty low. And frankly, Robert, they don't really, if your risk is less than $10,000, you're not going to take it anyway.
That's right.
So you're going to be okay.
Yeah.
That's
you have to pay it back, but you don't have to do any kind of report to them.
So you'll be fine. But if you don't, you're just rolling the dice, essentially. With every person that you don't screen, it's like, just think of it as going to the crap table, okay? Mm-hmm. Well, no, because you always lose at the crap table.
Next slide. All right, so home health and hospice, can they do their own screening?
Well, theoretically, they can. You can screen 5 people at a time.
Well, we're in Texas now. We're talking to Texas folks. Can Texas home health and hospice do their own screening?
Okay.
What would be required in Texas to do that?
Here's what you'd have to do. You can screen the office, the LEIE, the Federal Exclusion List, but you can only submit 5 names at a time, and then you'd have to go down the list 5, 5, 5, 5, and that's pretty tough. And then if you had to verify it, you have to have a social security number. It's theoretically possible, but if you've got 50, 100 employees, how are you going to do that?
And you typically have 3 times that many vendors.
And you have to do your employees and your vendors and your contractors, and you have to do
referral docs.
Your states too. Okay.
Oh gosh.
Now in Texas, for instance, you certify that none of your employees have been excluded from any state. And the only way you can meet that certification, you certify that on your enrollment application, and when
you say certify, you're swearing, you're attesting to that under penalties of perjury.
That's right. The document says I swear under penalty of perjury that I have conducted this survey and so forth. And so you have to, now all the states, now how would you do the states? Well, there are 44 or 45 state lists. Each one is different.
It's physically impossible.
I don't think anybody, it really is impossible.
But you can't just ignore it either, because, and say, well, I'm just going to do LEIE in Texas. Because now, if you ever do have a problem, some bad guy from Oklahoma comes in and you hire him. You hire some bad nurse from Oklahoma who had been excluded for some horrible patient abuse, okay? Now you got a real problem. Why did Martha Stewart go to jail? It wasn't because she engaged in insider trading. It was because she lied to the government.
And here's the thing. There's a good reason to do states, because with the nurse compact, right, it's pretty easy, and we've seen many examples for someone to be licensed in 6 or 7 states. It's not, and so if they get in trouble in one state, they could be on that exclusion list. It may not make it to the LEIE. It may not make it to you, and then they get in trouble. Then they move to the next state, and they move to the next state, and it happens not infrequently. And so if you screen, at least you are protecting yourself to the extent possible. If someone is excluded in a sister state, if someone's excluded in Louisiana, you're in Texas, so if someone's excluded in Louisiana or Arkansas, right, you don't want that person to be providing services because they're on that list for a reason. They may be a good person, it may not be great, but the fact is they're on that list. They're considered to be a problem. So why would you want to run that risk for someone who's already done that?
Now, Paul, every one of these folks, though, in their employment application, I'm sure they all specifically say, are you currently or have you ever been excluded? Why isn't that enough to say that in the application?
Well, first of all, please make sure you do say that.
Yeah.
Because we've seen
unfortunately, a lot of our clients didn't.
Nah, I've seen that. But if you know, they lie.
They lie because they're smart enough to know that if they tell the truth, they're not going to get the job.
Right. I mean, if I've been kicked out of Arkansas because I did patient abuse, okay, and or I was doing drugs or whatever the reason was, and I went to Texas, and you asked me if I have any trouble, am I going to say, well, yeah, they kicked me out of Arkansas because I was doing drugs or selling drugs? No, they're not going to tell you that. So,
right,
you know,
it's a real problem.
It really does make sense to screen it. And frankly, if you do it with exclusive screening, you could do it with any vendor. You feel free. Just, you know, talk to the vendors.
Now, just real quick, though, you mentioned 5 years. Most of these folks, even in bad cases, they're excluded for 5 years. Most of the time.
Yeah.
Okay. What about, it's been 10 years or 15 years, and the doc says, I've got my license back. As you can see here, I was only excluded for 5 years, so I'm no longer excluded.
Boy, that's a really good question, Robert. And that's something that's really important. I would say that here at exclusive screening, one of the many, maybe even most of the exclusions that we found that are improper, that shouldn't be there, are from people whose story is something like this. Oh, that was like 15 years ago, and I was excluded for like 3 years, but I got my license back. I'm okay with my licensing. I'm okay with the state. I'm okay here and there. And so it didn't even occur to me. The fact of the matter is, once you're on the list, you are on it until you get off. You don't fall off of the list.
It doesn't expire.
It does not expire. You have to. You either have and Frank, you know, you're either gonna die or you get, you know, or you can seek to ask. You can ask the OIG to let you off the list.
Now let's talk about that.
Okay.
When that happens, because we've handled bunches of those cases, what they do is they have you fill out an application, and it goes back to the very day that you were first excluded, and it will say, where have you been working since then? We have seen where they thought that their time was up, so on year 6, they started working somewhere, provider wasn't screening. When they turn that in, the provider then gets investigated because they were supposed to be screening and they weren't, and the individual is in trouble.
Right. So you know, it's a long, the application process is pretty difficult. And frankly, if you are on that list because of the licensing issue, you pretty much have to resolve that licensing issue. And that's one of the problems is they can't just say, oh, well, I'm now here. I've just withdrawn, you know, I surrendered it. That's not necessarily enough. So, but you can request it. And it's possible, but they need to do that. They will not fall off the list.
Okay. All right. So we've established pretty much that in Texas, because of the requirements that are imposed by the state, they have to hire a company to do the screening.
Pretty much. And, you know, you can use us or go to any, you know, there's an internet, right? I've heard of that thing. Yeah. And you can, you know,
But I would encourage you to look at exclusionscreening.com. Okay, because it's inexpensive, guys. I mean, this is the cheapest thing you can do for compliance out there.
I will promise you that it is going to be, if you have more than one office, it's going to be cost, for each physician practices anyway, it always costs less than the cost of the water in an office. I haven't done the analysis for home health, but think of that in the context of it's pretty,
next slide.
Pretty cheap.
Okay, we talked about most of these risks. You already went over those, Paul.
Yep.
Next slide.
So again, where are we? So most of the overall, about half of the are felonies and half are licensing. At the end of the day, it's one or the other, and that's kind of why the idea is that you really they don't really get on there for like obstructing a healthcare investigation, which is a basis for a permissive exclusion.
It is.
But I haven't seen any of those.
No, it's almost, yeah, the vast majority are license-based. Next slide.
So,
so really what we're talking about here is if you do run across one of these problems, what do you need to be doing?
Okay, so you have to figure out, well, so the first question is, you have to explain why you haven't been, either you maybe have been screening but not well and you missed it, or you haven't been screening. You have to explain it to the OIG. And if you come forward, now the one thing is, if you come forward on a voluntary basis, okay, then the OIG is reasonable in terms of the penalties.
They are.
They will basically want back all of the money you paid that person that came from the federal.
As long as, well, if it's an indirect billing.
Right. As long as.
And most everybody on this call is going to be indirect.
Right. Oh, as long as it's not a billing provider, it's reasonable. You get a lawyer, you get someone like Robert or anybody, really, a healthcare lawyer who understands the process, and you've done several of them, but anybody can, a good healthcare lawyer, and you go through, you figure out how it was, what they've done, you add up what they pay, you make a voluntary disclosure.
And we've never had one turned down.
And it's fine.
Yeah.
But if you know about it and you do the Sergeant Schultz I know nothing thing and you just close that's when you have a problem.
Yeah. And you can turn what is normally an overpayment into a potential False Claims Act case.
Exactly, because now you owe the money back and you're refusing.
And then they just do the same analysis you do for an overpayment. If you know about an overpayment, you haven't reported it and returned it within 60 days, like Jesus turns water into wine, it comes from being an overpayment into a violation of the False Claims Act.
Now, some people may not believe in the first one, but they definitely believe in that second one.
They do. Next slide. Okay, now, Paul, this is something we're only going to spend a minute on because it's so rare, but there are ways that you could still employ an excluded individual.
What you could possibly do is if you can put a silo and have them do something that's totally unrelated to a federal healthcare benefit program. Now, for a larger corporation that has multiple things that they're doing, right? They may be, they may have government business, non-government business,
and they have separate cost points.
Right.
Yeah, because that's the problem, isn't it? Because if you use 1 penny of funds that come from federal funds for their salary or benefits, you got a problem.
Right. So you really need to have it could be siloed. It's theoretically possible. But frankly, everybody in most healthcare organizations, particularly home health and hospice, they're supporting the mission. And the mission is going to get reimbursed by some payer. And so there you are. It would really be almost impossible.
Yeah. Now, number 3 is one that we have been successful in a handful of cases. When I say handful, I mean 3 or 4 over 30 years. And that is getting a waiver. We have gotten it to where the person they were so unique in the healthcare system, either because of their area of expertise or because of where they're located, that the government would issue a waiver.
I saw a list currently. There were less than 10 active waivers, so that's how rare they are.
Yeah.
It used to be the state administrator had to request it. Now the state administrator has to be consulted. The OIG has to request it. And it goes to the very top. And as you say, Robert, extremely limited in both where you can do it. Typically, if it's going to be granted, it's because they're in the middle of some area that is just dying for medical service.
Yeah.
And
like we saw a rheumatologist in South Texas where there was nobody within 200 miles other than him.
And they restricted it.
Restricted it to just his little area. That's right.
Exactly.
He couldn't go out of that area.
Exactly.
Well, not for Medicare.
Right.
Okay, next slide. All right. Problems, as we talked, it's not automatic.
Right.
Okay, just because you have a license does not mean that you're okay.
And I think that's important when you're on an employment application, because people will kind of forget. And I think it's important to say, now going back, did it ever happen? You might say, are you excluded or anything something that they could in their mind
because they may think they're not currently excluded.
Exactly. So there has to go back. Had it ever happened?
Have you ever been? Yeah.
And then what did you do to get off? Did you get reinstated?
That's right. All right, next slide. Now we're going to shift gears,
right.
Okay? We've been talking about the
last thing, states also have reinstatement processes, and they're different. State by state.
It's a heck of a system.
Right.
We were talking about exclusions that were being administered by the Office of Inspector General of HHS. Now we're going to shift gears and talk about preclusions. And as you talked about, how did we get here? Where did this come from? Well, it seems like it was yesterday, Paul, but it really has gone back pretty far now, back to 2018 when they first proposed this. Essentially, when CMS got out of the business of credentialing providers for payers, for Part C and Part D payers, that's when they said, if we're not going to be doing the credentialing anymore, then you guys got to take this on too. So, that's the problem. They pull the list together. But the payers are the ones, really the only ones, that have access to the list.
And the payers are required to screen that list.
Yes.
Now, theoretically...
And when we say payers, we mean only Part C and Part D.
Part C and D payers. And the people who are precluded, who are on that list, they should know that they're on the list, okay? Because they do get some sort of notice. But my experience has been that with exclusion and preclusion, when people are in the middle of criminal matters and there's
a lot of paper coming in,
and their world is falling apart, and they're not really focusing on this, they have so much stuff coming in, they don't realize.
And preclusion is like alchemy. I mean, it is so bizarre. Next slide.
And the lawyer may say, "Oh, don't worry about that. It's not." They may not be aware of it.
That's right. That's right. So let's go to the next one after that. Okay, so what is a preclusion? It really is a list of providers, suppliers, prescribers, okay, that CMS believes are bad actors, okay?
Right.
That's all it is. It doesn't mean you've been convicted of a crime.
I think it really, I take it to be people that shouldn't be, that they would revoke if they were active, or that they would deny if they were applying.
That's really interesting, because you're right. They don't even have to be participating in Medicare for them to be designated as a bad actor.
They don't. But I think that most of the people on it are, when they get someone who applies for regular Medicare, and they make the application and they deny it, because either a conviction or for whatever reason,
something in their background, they do not want them to be a participating provider in traditional Medicare.
And I think they ship those names, and they don't. But see, the thing is, the person doesn't really get. I guess there's some process involved, and I don't know how much.
Not much.
Not much. So the name goes over to the preclusion list, and similarly, when they come upon somebody and do a revocation, then they ship that.
So we're going to talk about the importance of revocations and that's relationship to preclusion in just a second. Next slide. Okay, so how are you added to the preclusion list? Well, there are two basic ways. And the first one, of course, is revocation-based. As y'all may recall, about 4 to 5 years ago, I say 4 to 5 years, it may have been 8. In my mind, it seems like it was yesterday. CMS went through the whole process of publishing in the Federal Register. They went through the comment and rulemaking process to greatly expand its revocation authorities. And as you'll recall, before, if you were revoked from being a billing provider, because if you're revoked, understand what they're doing is they're terminating your billing privileges, okay? If you were revoked prior to these changes, you can only be revoked for 3 years. Now, if you're revoked, CMS can revoke you for up to 10 years, which in many respects makes it more onerous than the exclusion provisions.
We have seen people, we have both seen people who have been reinstated by the OIG and are off the exclusion list But they're still under a revocation.
They can't get, and CMS is, you may not like everything that OIG does, but I believe that they're very intellectually honest and they're consistent with the way they approach these things. CMS, they don't want to hear about it. It is like pulling teeth to get them to back off on a revocation. We've done it, but it's not easy. Next slide. Just some of the revocation, there's 23 provisions now. This is just a handful of the ones I wanted to go over with you real quick. Look at this. This one pops up a lot with home health and hospice. Failure to report a change of location. Failure to post your hours and have proper signage. That's a big deal, guys. That's a big deal. Failure to report a final legal action. Let me see here. Failing to do a requested self-audit. If you're contacted and they want you to do a self-audit, you better redo it.
Basically, they want healthcare to become a world of paper pushers and not healthcare providers.
Well, that's how it feels.
That's my view.
That's how it feels for sure. I think though that they're like everything in life, just about. We cater to the bottom 20%. All of these things that they have listed here are because they have realized, wow, we needed a rule that says you can't bill for dead people. It's just craziness. The one that bothers me most, though, is the pattern of billing errors. And for our hospice friends on this call, right now, the PPOE audits taking place in Texas are scary because, you're subject to PPOE audit anytime it's a new hospice or there is and they define new as including a change of ownership, right? And we have cases now where they went in, they didn't involve us in the beginning, but they went in, they looked at 10 hospice claims, found 3 to 5 of them to be bad, and they have revoked the hospice's billing privileges, okay? Based on almost nothing. So this pattern of billing errors here for hospices especially is real problematic. And it bothers me because as with most of these programs, with PPOE, they started with hospice. It will be there for home health before you know it. With home health, they started with TPE. Now everybody in the whole country is subject to TPE. So these programs have a way of having a life of their own once they get going. So next slide. So revocation, that's the first one. The second way, so most of the people on the preclusion, that's the number one way they get added, is because of a revocation action. Number two, this is the one that's so squishy that bothers me. The second reason is behavior-based, okay, conduct-based. And, as you said, Paul, the individual or entity is engaged in behavior that CMS could have revoked them if they had been enrolled. So, this could be a case of first impression. They're coming into the system, never participated in the system before, but there's something in their background, and CMS says, well, if you had been in Medicare at that time, we would have revoked you.
It's making it, and the level of review is limited, so it's really, it is problematic. I think that most of these categories, well, on a revocation, that means they're already have a number, they're already billing providers.
Yes.
And so,
So this category is folks probably that don't have their own billing number.
I guess, but then why would they be revoked?
Well,
so I think that people end up on the list. How do they get that? Now, you have seen, I think, or there is a concern that when you resolve anything, any kind of litigation, and even though if that resolution, then I think that could just be, even if they're just doing an audit, a UPIC audit, ZPIC, but anyway, a UPIC audit, they could use that as the basis.
Well, they could, because it could show pattern of practice.
Exactly.
And it could also show improper prescribing practices, which is a separate basis for revocation.
Right.
Okay. All right. Next slide. All right. So, how will you find out about it? Now, this is what bothers me. They send it to them in regular mail. They don't send this stuff certified. And it isn't uncommon for people to tell us, I just found out, that I can't get on to Part C because I'm on something called a preclusion list. I don't even know what that is.
I never got that. And you know what? it's pretty likely that they didn't.
Right, because half the time they have the wrong address that they send it to.
Right. I mean, or they may, people move around. I don't always have so that's the address under which we don't know what address they sent it to. You might have changed it.
You may have changed practices.
We don't know where they sent it, but so they may not know.
Yeah. So, but guys, once you do find out about it, then you do have some due process rights to appeal it. Okay. You're not, in my opinion, you don't have much of a chance of getting off of it if the inclusion was revocation based, because once again, you can't attack the underlying action. If it was conduct based, you may be able to tell a story that maybe CMS might say, well, under the circumstances, okay, we're not going to add you.
What is unclear, because since it is that the penalty, what penalties you have if you as the provider can't search the preclusion list. So you can't but what if you knowingly find out that someone is on the preclusion list? Then I don't know how all that would work. I think the risks are that of your people, and who knows?
Okay, next slide.
It's ugly.
So we talked about how long you can be on the exclusion list. On the preclusion list, it's really based on the underlying action that the preclusion list jumped off of. So, for instance, if you're excluded and it's based on an exclusion, you're going to be on the preclusion list as long as you're on the exclusion list. If you're revoked, you're going to be on the preclusion list as long as you're revoked.
And I think as a healthcare practice, the practice or home health agency or hospice, you will know if you're on the preclusion list, but you won't know about your employees. However, it's important for you to kind of because if they're there, they may end up on the exclusion list or whatever. It's important to ask them about it, if they know about it, what they've done about it. I think I would recommend including that in the employment application.
Yes, I would too. Questions
about it and that sort of thing.
And then the felony, this one, we see this popping up all the time these days, because, you could have been convicted of a felony 8 years ago. If CMS finds out about it today,
yep,
they will put you on the preclusion list, and
they'll also revoke you.
They will also revoke you probably. There's just all kinds of things that they may do. Next slide. Okay, so can you all right, so we already talked about the screening. You can't screen Part C and D for preclusion. You just can't do it. You have to wait until you get a letter saying, you send us these bills, we're not going to pay them because the person that did it's on the preclusion list, or
as a home health and hospice provider, the way you would find out is that theoretically Part C and D are supposed to be screening the list, and they would be telling you you are employing a precluded.
Yeah, somebody showed up in these records that we identified as on the preclusion list. Next slide. All right, very quickly, I know we're out of time. We'll just take this another 2 or 3 minutes here. Let's compare them. Okay, the exclusion list, we talked about who that is. Primarily felonies on the mandatory side. On the permissive, it's everything under the sun. The preclusion list, it's either people that have been revoked or folks that qualify as bad actors. The exclusion list is across the board for all federal programs. Preclusion list is really just Part C and D. Next slide. Okay, in terms of the purpose, both of them really are to protect the public and to protect the federal fisc. Next slide. Who has access? Exclusion list, the public has access to it. You guys have access to it. The preclusion list, you do not. The only people that have access to the preclusion list are Part C and D plans. That's it. Next slide. Size of the database, about 85,000 or so on the exclusion or on the OEIE that's maintained by OIG. The preclusion list, it's supposed to include everybody on the exclusion list, but who knows? There are probably an additional 4,600 or so, or 5,000 on the preclusion list, not including the folks on the exclusion list. Next slide. Penalties. With the OIG, you can get CMPs, you can get assessments, administrative penalties, civil penalties, even criminal actions have been based on the wrongful employment of excluded parties. Okay. On the preclusion side, you could face CMPs. We've never seen it. It's fairly new in that regard, but there are rules out there that would allow it. Next slide. Okay. Screening matters. Okay, the risks are too high. Guys, you have to do this. It really is not a check the box situation. I know a lot of providers like to think of it that way, but it's not. And the government doesn't view it as that. They view it as this is a real and significant risk to the safety of our beneficiaries and to the federal fisc. We expect you to check this every 30 days, and we expect you to make sure that none of your employees, contractors, agents, or vendors are on the exclusion list. Next slide. All right, Paul?
So, you've really said it all with respect to with the importance of screening. I obviously believe in it. We have this company. If you sign up with exclusion screening, just call that number and say that you heard about this through Texas Association of Home Care and Hospice, or you can email me, or you can just go directly to the website when and you can schedule a demo, and you can you can tell them at that time that that's how you heard about it. You heard from me blabbing away, blah, 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 or that you listened to
So you heard Paul on a webinar.
You heard it on the webinar, 2 months, first 2 months free if you sign up for a year. Or check other ones, check other vendors as well. But please, 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 I've spent a while doing this now. Please do screen. It's really important.
And we understand that most of you probably are using somebody right now. The big difference between what Paul and exclusion screening does is a lot of these companies, they will email you back and say, oh, well, John Garcia pops up as a potential. And then you have to do the work to figure out, is it the John Garcia that has been excluded?
So
how's that different than exclusion screening?
Well, we verify. What you do is you submit the list and we do all the work. I've been in healthcare for a very long time. And I mean, I was, when they passed HIP, I was there in healthcare. And so what I understand, and I've been on both sides, I've been in government representing providers and so forth. We understand, we at Home Exclusion understand what you want. What you want is the least amount of work possible. You want to be able to upload your list and forget about it. And that's what I understand. So, and if you have a problem, you can always call me. But anyway, so.
Okay, next slide. Okay, and there's my contact information. There's Paul's contact information. I understand we've got a booth coming up at your upcoming conference, and that Heidi Kocher and Jennifer Papapanagotu, my partners, are going to be speaking at that conference. So please tell them that you heard our webinar and you said hi. And if you have any questions, always feel free to give me a call.
So there's one question up there. Is there a requirement for agencies selling their businesses to screen potential buyers? Now, I don't think
No.
The buyer would have the obligation to screen you, but I think the reverse would not be the case. That, you just need to screen, make sure of your people, not theirs.
Right.
All right. Thank you, everybody.
So that concludes today's webinar. Thank you for joining us, and thank you to our speakers, Robert and Paul. Everyone from today's webinar will receive copies of the presentation tomorrow via email. And if you have any further questions, like Robert said, please just reach out to them. And other than that, have a good Wednesday and take care.